I remember, I was a resident around the time Sumatriptan injections came out. And all of those are focused on the blood vessels. So I was interested to hear you say that when you give somebody Sumatriptan, the CGRP levels go down too, because in my head, the vascular medications are very different from the inflammatory ones, but there's sounds like there's overlap there, is what you're saying. Is that correct?
Triptan medicines are anti-inflammatories, and they also block CGRP, and they work not only on the blood vessels, but on these same nerves that we're talking about that activate with migraine.
Oh, interesting.
So the first monoclonal antibody release in May of 2017, and you would know the name Aimovig, but the generic name is Arenumab. MAB, monoclonal antibody, are used for many disorders, but in migraine, they are specific at blocking CGRP. The first one was Arenumab or Aimovig. A year later, we had 2 more. And about a year and a half ago, we had a 4th one. So let's just talk a little bit about monoclonal antibody first. So these are large molecules. And what that really implies is if you swallow them, they don't get absorbed. They need to be injected or put in intravenously. And within a couple days, they can start working, and the peak level is in about 7 days.
Yeah.
The first 3 are given by injection, auto injectors that people use at home. Mm-hmm. The 4th one is given intravenously, and it has a longer time in the system. It's a 3-month infusion.
Okay, great.
How well do they work? Looked at 1 month, 2 months, 3 months, and then there's 5-year data on the first one. Over 1 million people have used Aimovig. 65% of people are 50% better.
That's pretty good.
It's good. 42% of those people in the response group were 75% better, and 26% of those people are 100% better.
Oh my God.
What does that mean? That means if you look at a 3-month block of time, they had 1 month migraine free.
So I feel like what I'm hearing is that there are some people who are like super responders to these drugs. The people, the people who went down to, they had 100% reduction in their migraines. That's, yes, amazing. Okay, got it. Mm-hmm.
These are the first medicines that were specifically designed for migraine.
Got it.
Now enter the Gepants. These are small molecules, and they are used in pill form. And there are 2 of them. One is Gepant, and the other is Gepant. And you would know them by the name Nurtec or Ubrelvy. They can be absorbed orally. So they can be slow to onset compared to like an injection of a triptan, but they're generally exceedingly well tolerated with very few side effects.
Unlike triptans can be.
Patients were requested to wait until the pain was moderate to severe, and we know there's a much better response if medicines are used earlier. So the 2-hour pain-free when they waited was only 26%. But if people treat early, the pain-free is double that.
Wow, okay. So very much like the other medications, the sooner you take it, the better?
Yes. So it's an every other day pill. And what is the advantage to that? She could choose to take it every other day. Okay, now she might be doing beautifully. She doesn't need to take it every other day. She can use it if she gets migraine. So this is the first medicine that has ever been approved for use both preventively and acutely as needed, and you can kind of flex back and forth.
Yeah, and what you're describing is dramatically different from all of our other migraine preventives, where you typically have to stay on them 2-3 months before you decide that they're not working and give up. So, that's a whole new level of flexibility that I'm sure none of us here are used to having, to be able to stop and start your preventive, if you're having a bad week or a bad month.
A little bit about the response rate for the Gepants, Amelia. In people with less than 14 days a month, if you look at the data's only for the first 3 months so far, there were 4 less migraine days per month, and the effect was seen within 1 week. So it's quick. In patients with chronic migraine, which means more than 14 days a month, it was 6 less days a month.
Yeah, I'm curious, is there speculation within the headache community that these medications will continue to work better over time, the way the monoclonal antibodies do?
I think the speculation is that yes, they will, because they were looked at for a whole year in the safety and tolerability trials that led to these becoming preventives. They said, well, if people are using these acutely and it's more than 10 days a month, are they going to get worse? Now, there's other medicines coming out preventively that are in the same family. There's one pending FDA approval called Gepants. And there are nasal sprays coming out that will work faster than pills. So there's a lot of activity based on CGRP in the management of migraine.
How long is it supposed to take Gepants to work?
Is the question how long to take them to work acutely? I have the rare person that says I'm better in 20 minutes, but that's the exception because they peak at an hour. Nurtec peaks at an hour. Ubrelvy peaks a little bit more than that. It depends whether you have food in your stomach. If you have food in your stomach, it depends whether it was a fatty meal. So there's a lot of other indications, probably an hour. Let's say a triptan works better and it's much, much faster, but the migraine recurs. I add a Gepant to the triptan because the goal is migraine-free in 2 hours, not coming back in 24. So sometimes people need a little cocktail. So how long should it take? The goal is always migraine-free in 2 hours.